So we cleanse the area, all sterile techniques, sterile gloves, mask, everything like that. Identify, and we've already felt your hips there on this side of the iliac crest. We're probably at about the L3-4 space right here. The first step is just going to anesthetize the skin, so a little poke here, and just inject some local anesthetic. And then out and raise a bleb on the skin surface. Once that's good and frozen, our sharp material there. Use the epidural needle, so that's a marked 9 centimeter TUI needle. And so first step is just seeding that into the ligament, so I can feel that kind of bite into the ligament, and then we're going to use our glass syringe here. So we use a loss resistance technique to air. You can use liquid as well too. You can use water, the other choice. And basically, I'll show you with the syringe how it's quite ballotable at this stage. See, it bounces. And as we move up, for that bouncing, I'm also feeling with my fingers here the depth that I'm going. I can see the centimeter marking, so I'm just moving a couple millimeters at a time here. And you also get a sense from the end of the needle telling you if you get through the ligament inflavum is the last thing. So we're going through the interspinous or the supraspinous ligament, intraspinous ligament, and then ligament inflavum, and stopping right after that. And then we get into the epidural space.
Can you just give it my belly button?
Yeah, exactly. We go that far. We've taken a wrong turn at Albuquerque. So now we get a nice loss of resistance there. So, and I could feel that with the needle as well too. So we're going to come off, no fluid coming out of there, which is what we expect. And then, so we're about 5 centimeters in the epidural space. There's 4 centimeters up, which is thin, guys. That's about what we expect, 4 or 5 centimeters deep. So I'm just going to connect my syringe here, brace the needle so we don't move, and just slowly inject. And Jeff, you may get that characteristic sort of ache into your back or pressure, like you may remember from before. And just nice and slowly. Don't aspirate on the needle, because the idea is the needle in the epidural space is just sort of floating there, and if you apply negative pressure, you might suck the dura, which is the sac that surrounds the spinal cord, up to the sharp edge of the needle and then poke a hole in the dura. We don't want to do that, because that'll give you headaches and that kind of stuff.
Nope. Ooh, I can smell tar.
Good. So then, when we're done with that, you just wait a few seconds just to let that pressure equalize, come off there. So that's good. So that's a good sign. Nothing shooting out, so we know we're in the epidural space. And just holding the needle in the same place, dial it back in, and then just come out all in one motion with that. And just put a bit of pressure for the bleeding there.